one of the things that I consider myself to be very lucky about is that I found out in a time and in a context where I had access to a lot of community. So this was when I was 15, I got to meet intersex sociologist Georgianne Davis, and that's Pigeon, who's very well known as one of the faces of US intersex activism stuff. And that unfortunately is still uncommon. So having access to multi-generational community as a young person, when you're going through such rough experiences, and that was the case for me, going through medical experiences in my late teens, high school, college, being born without gonads and forced into what I sometimes conceptualize as an unwanted transition. So, medical interventions that were surgeries and hormones aimed at fitting me into an idea of what a white woman, what a person is supposed to want and to look like in terms of fertility and body image and outcome, without really asking me what I wanted in terms of any of those outcomes. And all of the care that I received was delivered in a way that was framed as for a future husband. Those were the words that people kept saying to me. And so my goal in speaking to med students and across institutions is to promote individual patient-centered outcomes when caring for intersex folks and when talking about the issues that affect us. So most folks, if they have any exposure to this at all in med school, come across intersex in this medical framework of here's XX chromosomes, here's XY chromosomes, and here's everything that can go wrong in a taxonomy from there. And that approach has its place. But if that is your only approach, that is severely lacking, because to understand something like this, you really need a lot of different contexts coming together. And that's what we have in this panel. So fantastic. Intersex bodies have one difference, at least in one component of sex, according to sexologist Anne Fausto-Sterling, who's one of the big academic names in this field. And sex can mean a lot of things. It's a lot of different characteristics of the body. And so when we think about how human bodies develop, most people, we think, follow either one of these linear paths in a very neat way. So it starts with chromosomes, then you develop internal gonads, external genitalia, and then puberty kind of blends together all of these characteristics into secondary traits. Intersex people do not follow directions. So there's something that either is different about these paths, or you've added something, subtracted something. I don't have time to get into all the different ways that that can happen, but the emphasis here is that intersex has to do with the way that your genitalia, hormones, chromosomes develop, and that being significantly different or unique, I suppose. So that can be chromosomal variations, which is complicated because there are a lot of issues around genetic counseling, selective terminations. Now that intersex differences can be pinpointed by medicine, that makes intersex action being very dangerous in different ways, depending on where you live and what kind of community you come from. There are intersex differences in terms of the internal anatomy. So if you have ovaries, testes, a mixture of both tissues, or neither, there's a lot of different ways that a person can develop. The ratio of hormones that your body makes. So we expect that most men make more testosterone and most women make more estrogen. That's not always true, as well as how your body's able to process those hormones. There's a lot of variation across the board. And heads up, I'm going to show a couple of graphics that include drawings of genitalia. This is Sex Week, so hopefully that's cool, but I always want to give folks a heads up. And to emphasize that not all intersex people have genital variations, but I'm choosing to talk about this here because I think that especially in Sex Week, especially with people who might become, biologists or healthcare providers, it's important to know what is realistic and what can actually happen. So all the genital parts are kind of sliding spectrum. So everyone has erectile tissue, whether that's small inside and clitoris and larger outside and penis. And so of course it's possible that some intersex people will fall somewhere else in the middle on that spectrum. Same thing with scrotum labia, the tissue that protects that internal reproductive anatomy. And same thing with kind of having a vaginal opening versus fusion. So you can see in this diagram that there are different kind of midpoints at which you can fall on some of these spectrums. And genital differences are probably a minority of intersex people, but it's still probably most people's mental concept of how that works. So it's not really a both, quote unquote, so much as it is a series of points on spectra. And I love to show this visual by an artist of, clitoral and penile tissue is clitoral and penile tissue, excuse me, is extremely similar. It's the same stuff, just kind of rearranged in a different order and size. And this animation never works, but it shows kind of how it shifts between one and the other. And likewise, this is an artist who paints pictures of vulvas, and even among people who aren't considered maybe intersex or trans in a medical context, like there's so much variation. So the question is, where do you draw the line? And that's actually a very contentious question politically right now. So I emphasize that intersex also means a lot of different things to different people. It is an umbrella term, and people use it in very different contexts. So it could be the umbrella of medical diagnosis terms. It could be an adjective, so like intersex genitalia, describing an adjective of seeing those different points on the spectrum. And it also has to do with being a community label for people who share these social experiences like discrimination in healthcare, struggles with infertility, abuse medically or treatments because of their difference in sex characteristics. And it also is linked as an identity term, sometimes associated with LGBT movements. We view it a lot in that lens, through that lens in the United States. And as I'm sure my medical colleagues will talk about more, the issue is surgeries that are forced onto children. Intersex people very rarely get the option to keep their own bodies if they choose. So it's kind of this other side of the coin to what we're seeing with trans issues. And there's a lot of parallels to LGBT conversion therapy because especially we view it that way often in the United States, but trans kids aren't trusted to be able to change their bodies, and intersex kids aren't trusted to be able to keep theirs or have the option to keep theirs. And this is what intersex movements have been saying since the internet enabled them to first meet each other in the 90s. This is 96 versus today, a protest of Dr. Dix Pappas in New York City, who's one of the leading surgeons on some of these infant clitoroplasty techniques. I always like to ground this in history too, because I think it's important to understand some of the systemic forces that got us here, because as with all social issues, it's the usual culprits, right? And so, particularly in the way that medicine has developed as an industry, it moved from being something that was done mostly by women, mostly in the context of communities themselves in the home, to this thing that's become an industry, that's become professionalized, that's become hierarchy, that's become, the medical field that we have today, that's this big thing that's very hierarchy based, right? And so this comes from a history of how, European academies viewed medicine. It came from how European governments centered everything around marriage and record keeping. And that was on the crux of penetrative sex and of childbearing. And the existence of intersex people was very threatening to that. And not only to that, but on to the idea of all social hierarchies. So if sex wasn't this permanent, true, binary thing, then did that threaten the racial hierarchy as well? Like, what other truths did the existence of intersex people threaten? And so medicine actually became pretty much an enforcement to retrofit bodies into these social panics and these ideas. And it was always, of course, about racism. So there's a lot of deep and intertwining histories here. This is a talk that was given recently by the group Stop IgM, but Nazi texts very much reference that intersex differences were a result of quote unquote degeneration. There were a lot of stereotypes around Black and Indigenous people and intersex traits being sort of intrinsic and a factor of race, as opposed to white people being more elevated, more quote unquote civilized. And that's where the idea of even opposite sexes came from, was that white Europeans were further apart in their sexual differentiation. So that was always very rooted in sort of gender and sex being a function of race. And in terms of medicine being historically like a very European industry, like based on these sort of colonial ideas and enforcements. And that goes into the John Money era and the treatment of intersex children. And as well as, I think this was kind of what I touched on, but Histories of the Transgender Child is a fantastic book that goes into that a lot deeper. And as to who we see, bearing the consequences of this policing of sex and gender. So we see it in a modern context in sex sports testing, and who is it that gets subjected to sports sex testing and thrown into the media against their consent? It's usually not petite, white, quote unquote, feminine women competitors. Those are often the people who are joining up in favor of policing sex characteristics and womanhood. And I'm sure Kyle will have some fantastic things to say about this, but there are a lot of modern stakes. So the legislation that is terrorizing trans communities right now explicitly includes carve-outs for continuing forced infant intersex surgeries. This is work that Human Rights Watch is at the forefront of. And we see all of these appeals to phrases like chromosomal sex and biological sex. So there's this appeal to quote unquote science and sex as this immutable, permanent answer that's written on people's bodies to erase trans people. And that is also dangerous for intersex people, as we see in some of this legislation. So I want to end with offering some great resources, especially if folks are anywhere near biology or pre-med med. There's some really awesome organizing that's happening. This is Columbia Students for Intersex Justice that partners with Intersex Justice Project. They hosted actions. And just recently, we launched a Slack group for medical students, but all folks in health professions and sort of relevant fields are welcome to join up, find a space for justice and values, sort of folks who share values in medical and health fields. It's a real cute space so far. I'm really excited about it. So I wanted to offer that as a resource too that folks can hop on to, as well as contact info and some of the many resources that Interact has developed in partnership with organizations like Human Rights Watch, excuse me. So I want to not take up too much time and hand it off to my fellow panelists.
I don't know, Hans, I can listen to you forever and look at your graphics forever, because I'm always very ashamed of my slideshows after seeing yours. So maybe I'll just ad-lib it. Hi, I'm Dr. Ilene Wong. I am an adult urologist who is also on the board of Interact at for Intersex Youth. And I came into this space of intersex advocacy through an index patient. So any of you who are about to go into medical school or thinking about medical school will know that during the residency period, you're essentially, a student still, like you're learning from teachers. And so I will always remember not learning from my teachers, but really learning from my patients. And specifically during my residency, I was involved in a surgery that removed an intersex teenager's gonads. And I didn't realize it then, but that was sort of the turning point that made me realize how poorly my education, specifically my medical education, prepared me to take care of intersex patients. Because, one of the things that the Interact often says is the I in LGBTQIA doesn't stand for invisible. It stands for intersex, not invisible, but it feels sometimes that it stands for invisible because there's so much stigma and shame attached to it, and there's so much lack of awareness of it even within the medical community. Admittedly, medicine is hard. There's a lot to learn, and I hope that all of you who watch this will realize that we can't compress all of intersex history and awareness and biology into 1 hour. That this is something that could be a year-long course for sure. So my goal or my task today is to talk about what medical providers can do for intersex patients. And the best way to, I think, approach intersex care is to be aware of the history, as Hans said, of irreversible surgeries being performed on intersex children. And you can't really be a provider for intersex, a good provider for intersex people without being aware of the intense trauma that has been that the intersex community has been subjected to in the past in terms of surgeries, in terms of concealment. I'm happy to share my screen as well. I'm going to try that. You guys see part of it? Okay, maybe not the medical record behind it. Excuse me, I'm going to log out of that part. All right. Okay. anyways, maybe I should have tested this beforehand. But when I talk about trauma, I talk not only about surgical trauma, but I also talk about the trauma of the medical gaze. It's something that Hans is deeply aware of as an intersex individual themselves, that so much of the psychological trauma that was placed upon intersex children has to do with being exposed to parades of residence, has to do with, not having any sense of bodily autonomy when choosing what their medical care is going to look like. So the first thing I tell anybody who is interested in intersex care is to use what's called the trauma-informed approach to taking care of your patients. And what a trauma-informed approach involves is understanding that your patient has a history with the medical profession, namely a history of things being done to them, the assumptions being made that they wanted to do certain things when in fact they didn't. And by knowing the history that the intersex community has been subjected to, you're able to reduce triggers and opportunities for re-traumatization. Because the fact is, there's no other specialty within medicine, I think, where I have been so aware of the importance of words. Studies have shown that even the names that people use when talking about intersex diagnoses can cause patients to change care, go to different providers, and even just not go to medical providers at all. And so words really, really matter. I'm going to try once again to put this up. And there, does that sort of work in some ways? I'm going to have to share just that. Do you guys see that? Okay, great. So as this slide suggests, we really are living in the midst of an intersex health crisis, where, as I said, words matter. And words matter because using loaded language, talking about disorders of sex differentiation as opposed to differences of sex differentiation, when talking about ambiguous genitalia as opposed to atypical genitals, all those words are words that judge patients, that make them into an objectified patient that is sort of constantly under the medical gaze. And by objectifying patients, we as physicians allow ourselves to make decisions for them, to maybe not always assume that they are able to take care of their own decisions making, particularly in the case of intersex children, who very often obviously are at the mercy of their parents, who can be subtly pressured into having surgeries performed on them, and who often have the consent process with all these surgeries glossed over. So when we talk about intersex care, I'm talking about giving power back to the patients. This is an example of an actual Facebook post by a friend of mine who was an intersex, who said that they just saw their urologist and told her, "I wish I'd never had the surgeries I had to the baby." And the urologist's reply was, "Yes, you do." Hopefully anyone who's out there, even those who haven't gone through medical school, will understand why this is not the optimal doctor-patient relationship. However, it is unfortunately very common. As I said, intersex patients often used to have their diagnoses concealed. Children were subject to repeated genital exams, and gonads were removed, even though there's much more data showing that most of the time these gonads are not cancerous, or at least do not become so until much later in life when they can be monitored. The history of surgery to fix intersex children, as Hans alluded to, is checkered with poor outcomes, with sexual dysfunction, vaginal stenosis, dyspareunia rate, and perhaps even most devastating, oftentimes organs were transformed via surgery into the a gender that the child later on does not even identify as. And so I would certainly posit that medicine has failed the intersex community. It's showed the limits of medical education. I would say that unfortunately, the amount of education I had during residency on intersex care was maybe 20 minutes in an endocrinology unit. It wasn't until later on when I was actually a resident that I actually saw an intersex person and met them face to face and became aware when I was treating this patient that, you know what, this surgery is not necessary. And in many ways, the best thing I can do for this patient is to connect them with peers to realize that they're not alone and to help them as they move forward, to realize that their bodies are, not disordered and that they, in fact, are part of a, healthy, thriving community. Particularly, I would say that anyone who's taking care of intersex needs to realize that no one doctor knows everything there is about intersex. And in particular, that's a problem for intersex kids because so many of them have to transition care from pediatricians who might know about their bodies when they are as kids and moving into adult care where a lot of adult internal medicine doctors and family practitioners don't necessarily have the knowledge to be able to treat the hormones that they might need, the potential follow-up surgeries that they might need, not to mention the incredible psychological burden that a lot of intersex patients have to carry with them and need to deal with on a daily basis. And so another take-home message I would give all of you is to realize that humility is a really important part in taking care of these patients because you need to load the boat. You need to have access not only to a urologist or a pediatric gynecologist, but also to an endocrinologist, to psychiatrists, to social workers. And this is a true example of like total patient care. So what can we do to regain the trust of intersex patients? As I sort of alluded to, the medical gaze is pernicious. So if you ever are in medical education, work on reducing the impact of the medical gaze and reducing like teaching moments that invade people's privacy. Educate your office staff because I've heard too many stories about intersex patients who present as female being asked for pregnancy tests when they don't have a uterus. I've had too many instances of people trying to get hormones because they had their gonad surgically removed, but then being told that they don't provide trans care. And as I said, multidisciplinary clinics are key. I'm not sure how much we want to get into the weeds of the science around this, but this is a graph that shows, this is a chart that shows the rates of cancer in many intersex conditions. And you'll notice that in many of them, they're exceedingly low in single digits, meaning that they're less common. It's less common than the man's lifetime risk of prostate cancer, for instance, and you don't take every prostate out. And I have a final learning slide in the end here that I'm going to talk about because I think that I'm happy to come back and go through more detailed slides, but I want to emphasize that peer support is still the best medicine for most intersex folks. And that intersex is not a surgical emergency, even though when I was a resident, they used to say it was a social emergency for parents. However, that could be treated with referral to social work and psychiatry, as well as access to parent support groups in addition to peer support groups. And I think that covers all my take-home messages. As I said, this is about 1/10 of the minimum I would recommend that anyone who's going into medicine know about it, but I'm happy to answer any further questions in the Q&A.
Thank you so much, Dr. Wong. I believe that Dr. Kreuzer was able to pop on in, so I'd like to welcome you to Dr. Kreuzer.
Hi, and I'm not in prison, I'm on a balcony. So I'm a physician, and actually, as my training is really emergency room, and I have an addiction medicine fellowship. And now you might ask yourself, what the hell am I doing in intersex? It's because I was born with intersex characteristics. I actually have what you call over-testicular DSD. I have, I'm somebody who has an inbuilt defense against genetic testing because I have two different genetic types in my body. I have cells with XX, some cells with XY, and basically I have what you call 46XXXY mosaic chimerism. And this has been known ever since I was born. Initially, people thought I was a boy because I really looked more like a boy, but then they realized I have what you would call penoscrotal hypospadia plus another weird opening that they couldn't explain. So they actually just, and I was born in the 70s, so that's a long time ago. They didn't really look that thoroughly into, you know, oh, let's do, they just did a karyotype and they just found my XX cells, which not surprising because I believe I was told they're about 70-75% of my body. And look at me, so much to your chromosome determine who you are. Hello, what about this says woman to you? I don't know what. Anyway, but I was assigned female at the time. My dad was Diné, which translates to Navajo for the most of the non-natives. And as such, he had a natural distrust into the medical system. And he basically kept me out of it as much as he could. He knew that they wanted to do surgery on me because they wanted me to turn me into a real girl. And as you can tell, that probably wouldn't have worked well. So I was never, I had disadvantage to other people. I was never subjected to surgeries. And eventually, when I was initially diagnosed back then as a female pseudohermaphrodite. Eventually, a few years later, we moved from Quebec to Germany with my mother, and there a doctor saw some Blaschko lines on my back, and they redid the karyotyping and realized that I had a mixed karyotype, but nobody ever asked me anything about what I wanted to be, who I wanted to be. As a matter of fact, the general thing was when I was a child sitting in the doctor's office that everybody talked over my head. So I personally decided, you talk over my head, I'm not going to talk to you. So I never opened my mouth. Everybody thought I was crazy. My mother was told to take me to a psychiatrist because I'm that crazy. So then I said to my mother, I'm not going. And if you try to make me go, I will run away and I will disappear and you will never see me again. And I was a feisty kid. My dad was in the military. He basically gave us basic military training when we were toddlers. So I can say I spent the first 8 years of my life in boot camp. So I was able to stand up against my mother when I was about 9-10 years old. So just to put that in perspective. You know, how did I end up becoming a doctor? Because I really hated the medical profession. I hated hospitals. I fell one time when I was a child. I built my own skis and tried to ski down out of wood boards and tried to ski down a hill, fell and broke my arm. I didn't tell my mother. I didn't tell anybody because I didn't want to end up in a hospital. And eventually my arm healed, but now my radius is a little crooked. Anyway, so, and this is the kind of person I was. I mean, I just took whatever I could, but I wanted to stay out of any med because the only thing they could give to me was, oh, don't you want to be like a real girl? And this was just not me. It was not me. I was given hormones because my puberty really didn't go exactly the way they thought it would. And, you know, eventually I convinced my mother to just disappear from the eye of anybody who was a physician. So, I mean, this is really, maybe I was lucky or I was too radical or my mother was not tough enough to stand up against it. directed my care. My older sister, interestingly enough, went to medical school. And I wasn't planning on that, but we were in Germany. And at that time in Germany, they had an entrance exam for medical school. And I said to myself, okay, I'll take it. And I was still in school. You took the entrance exam oftentimes when you weren't graduating, when you hadn't yet graduated from school. So I took the entrance exam and I said to myself, if I'm among the best 10%, because this was a sure in, I'll go. And guess what? I was among the best 5%, which wasn't as good as my sister because I was never as smart as my sister. But, I said, okay, I guess that means I'm going. And, really, I sound so secure and all that by myself. Understand that this was me with definitely a more male trajectory, with a female assignment and all that I tried to ignore as much as I could. So I was the most, butch and feminine female you can think of. Everybody probably thought I was a lesbian. I didn't care. It didn't matter to me. I liked females anyway. But I know that no self-respecting lesbian would ever have any attraction to me. I was realistic about that. So I did my countermeasure, and I really don't recommend that to anybody because it's crazy. And when I look at my life, I think it's absolutely crazy. Was a kind of level double life where I had to have that female person over there and my male person, he did his own thing over there. So family and other people, official, the rest recreational, someplace else with another thing. So I know it sounds deceptive, it sounds bad, but I didn't care. So that's how I survived for a long time. So as I told you, I was half American because my dad was in the US Army and we were technically US citizens. My sister, after graduating from medical school, already went to the United States. I had visited my dad a few times in Los Angeles when he lived there. And if you are a kid, live in Germany and you visit California, you feel like, oh yeah, that's where I want to be. Oh, no, I want to move now. So I basically, in my head, I have to move to California. So then that's what I did. And my sister was already here, which was easier for me. Eventually took all my exams and did residency here. And I also transitioned as a trans person here in the United States. And that was also actually fairly easy compared, even if it was harder back then, easier than it would have been for me in Germany to do that. So definitely there was an incentive to actually get that done. So what else was I going to say? I'm losing myself. Yeah. But once I did that, I could actually be very much in denial of who I was. And the reality of it was we were always told you're by yourself, you never find somebody like you. And that was actually the truth. For the longest time, I did not. I was not connected to intersex. I wouldn't even have connected myself to intersex because I learned of it back then. AIS was called testicular feminization. What does it have to do with me? I knew about Kleinfelder. What does that have to do with me? CH. What does it have to do with me? So I wasn't really identifying with that. I was just, living my life. I'm a man, end of story. And it came until I was kind of in a sort of a life crisis about 10 years ago. And I actually found a friend in the trans community, realized after going to 3 of these trans meetings that it wasn't me, that there were a lot of things that I absolutely did not understand. There was this absolute adoration of testosterone. Like, oh, people, it's a hormone. I mean, I get it, you like it, but I felt it was almost like a cult. And I could not. I was like, and there was a lot of things they questioned, and I totally get that, but I would have never questioned that about myself. So this didn't fit. Again, not fitting. But my friend actually connected me to another person who was an intersex person. And that's how I found the intersex community. And once I found it, it was like, something exploded inside of me. I went to a conference in San Francisco in 2013, and lo and behold, in 2014, I started advocating as a physician and an intersex person for the intersex community, and have done that ever since. I'll be the keynote speaker for the upcoming Southern California LGBTQIA health conference that's going to be at the campus in the Kyleigh campus in Pasadena on May 13. In case you guys would like to check that out, I highly recommend that. It's not going to be just intersex, but the whole spectrum, but it's a really great conference. And there's a few things that I learned in the time that I did this, because like I said, I had to approach intersex on my own. I had to first accept myself as that. And as I was going through that journey, I realized there's one thing that we're doing completely wrong. And it's so fundamental. It is equal to saying the earth is flat. And that is that biological sex characteristics in human being are not binary. They are not binary. It's not a binary sex that we have. In reality, by nature, human beings, just like most other beings that have different sexes, are non-binary. And that is really, at one point, I realized that's kind of the key to certain things. If you look at it, even in the presentation that I just saw, there was a lot that was way too binary for me. And I only have 1 minute left. So please don't think binary anymore. Here's the thing. I'm an intersex person. What about, do my chromosomes determine who I am? How would they determine who I am? So I'm of sex and intersex person. So I should identify as an intersex person, so not as a man or a woman, because you're stuck with that, if that's actually how it works. My body parts, I do have a small unicorn uterus, although outside looks more male. So how does that work for you people who want to say, oh, if you're born like this, you're that, born like that. What am I? So again, intersex, it is a separate sex category, or whatever you want to call it. Maybe sex is fluid. But keep this in mind. It is as, how would I say, I don't want to say the word dumb because that's not acceptable anymore. It is as ignorant as to say the earth is flat, to insist that sex characteristics are binary. And think about this. Even gender identity that a lot of times gets split up into cis and trans, where do I fit in? I don't fit in. You could say, oh, but you transitioned as a trans person, but I'm not. I realize, knowing trans people, I'm not a trans person. I love them. They're great. I support them, but I'm not that. I don't belong there. Not 100%. I understand things, but I don't belong there. So really, what gender identity should an intersex person have in this model of their sex equals your gender? Because it does not, it never does, not for anybody, whether you're intersex or not. It does not work. It is non-binary. There's no cis and trans. There is endosex, where people identify with the sex that they were born in, and there is intersex, where people are assigned a sex that is not even theirs. And then there's trans. But there is no binary. Humans are not binary. And I've heard arguments like, but gametes are binary. It's bullshit. It's two cell lines. It's two different cell lines. A cell line does not define the whole concept. So anyway, please, if you take nothing else from what I just said with you, take this with you. Do not buy into binary concept of biological sex, because once you don't do that, here's the important thing. How can you tell somebody what gender they are? Because if sex is not binary, how can gender identity be limited to a certain chromosomal pattern or to certain physical qualities? How would that work? If it doesn't work for intersex people, it wouldn't work for anybody. Same with sexual orientation. In intersex, what is same sex for intersex people? Having sex with an intersex person, so you can have sex with a woman, let's say typical woman or typical man, then it's still the same sex, right? So intersex people only have sex with intersex people? Does that make sense to anybody? So same thing with sexual orientation. if intersex exists, can you just say, well, you're a man, so therefore you have to be attracted to women. You're a woman, therefore you have to attract. Just think about it. It all goes out the door. The problem is we don't acknowledge the non-binary of biological sex. We don't internalize it completely. And it's a hell of a thing to do because our whole language and everything we do is directed at that. And intersex is just not a disorder. It is just a variation. Your body is just not typical. We are about as rare or as common as real redheads, but percentage-wise. So is being a redhead a pathology? It's a genetic difference. It is genetically determined. So does that make it a pathology or is that just a variation? So if redheads are not a pathology, only a variation, then we are not a pathology, we're only a variation. Let's see, that's all I had to say. Sorry.
Thank you so much, Dr. Kreuzer. I appreciate you sharing your story with us today. And with that, I'd like to introduce our last panelist, Mr. Kyle Knight.
Hi, how's my audio? It's okay? All right, I've had a little bit of wonky internet today, so if it cuts off, I won't be offended if you just move on to the Q&A and just forget that I was even here. But for the minutes that I'll take up, I'll try to be brief and touch back on some things that my panelists have already, my co-panelists have already mentioned. One thing that, just for background for me, so I am a senior researcher on gender, sexuality, and health at Human Rights Watch. I'm based in San Francisco. Human Rights Watch has 600 staff spread out around the world. We work on a wide range of human rights issues in over 100 countries. And we, since 2016 or so, have worked on intersex issues. And I've had the pleasure of maintaining that relationship primarily with Interact here in the United States and with other groups around the world. A couple key takeaways from a human rights perspective. The first to know, and I'll try to illustrate this, but we could spend an entire semester unpacking it. But every single human rights institution in the world that has considered the issue of medically unnecessary, non-consensual normalizing surgeries on kids born with intersex traits has deemed these surgeries a human rights violation. Every single one, right? And that ranges from organizations like nonprofits such as Human Rights Watch, but it also goes into official jurisprudence. So since 2011, so just a little over the last decade, there have been more than 50 individual instances where United Nations human rights treaty bodies have examined the evidence, have taken complaints into consideration, and have deemed these surgeries a human rights violation. These come from all different countries. These treaty bodies are committees of global experts in law, in medicine, in human rights activism, who have to reach a consensus over these types of things. And over 50 times in the last decade, when this has been brought to them, they've deemed it a human rights violation. A lot of the focus here in the United States, as my other panelists today have outlined, is pushing back against this default to surgery paradigm on kids. And the map that Hans showed really briefly illustrates an earlier version of the kind of dumpster fire that is sweeping the country right now that we're all familiar with. There's over 450 pieces of legislation in state governments right now being considered that in the headlines seems to target mostly trans kids and try to stand between them and the care that they want and that they need. But in so many of these bills, they also have a carve out that says, well, but if you're born with one of these intersex variations, yeah, go ahead, do all kinds of non-consensual, unnecessary, medically normalizing stuff to these kids. And I think in some ways we could be flippant about this and we can say this is 2 human rights violations for the price of 1 in this terrible legislation. But I think it also really gets at the core of it, that the history of this hyper-medicalized paradigm, the history of how intersex bodies have come to be understood in popular culture and in medical literature and all across the ways we come across information, has been about normalizing, has been about controlling, and has been about maintaining power over who gets to count as what type of body and what type of person, and not actually about anyone's health or autonomy or rights. And so I mention this not because it's not obvious or other people haven't thought about this, but just to emphasize that if this is the first time you've come to a seminar to learn about this, a lot of other people have gone on this journey, right? Myself included. And it can be completely overwhelming. But I think, as much as Hans pointed out that intersex bodies don't really follow directions, I think we can all follow the direction of just not letting these assumptions guide the way we're going to learn, guide the questions we're going to ask. But to sort of look at context, zoom out a little bit, question some of these assumptions of the binary nature of things. Because if you look in other places around the world where the default to surgery paradigm didn't take hold, either because there's not as many surgeons, or because there's not as much access to industrialized medicine, or because local culture and social norms have led people to embrace bodily diversity instead of try to erase it, or so on and so forth, you see people with intersex variations growing up intact, maybe not fully having information about their bodies, but certainly not operated on. And then you see the same type of bias and bigotry get played out on them as adults. And let's be clear, what I'm talking about here is largely about global sporting competitions where this comes up. And so if you start looking at the regimes of sex testing, you're looking at predominantly track and field or athletics, and swimming also has a global policy now. But zoom out, pay attention to the context. Who's making these policies? Well, you can look at the boards of these organizations and see that it's primarily people who are white, people who live in Europe and North America, and people who are male, who are making these regulations about who gets to count as a woman for a competition, and what traits are admissible and which ones are not, and which hormone levels are offensive to the idea of womanhood, and so on and so forth, right? And then you look at who the policies are affecting, and you see that the people whose lives are destroyed by being publicly exposed and having their anatomy discussed without their consent, by having their livelihoods taken away, by being completely humiliated over something that they were blindsided by from a blood test. These are predominantly women from the global south, from Africa and Asia, who do well and are having some success. And then the system that's designed by people from a different part of the world and who don't have this experience is telling them, no, you can't do well here. We're just going to rule you out. We're going to make you ineligible because it offends our notion of the norm. And it really is that arbitrary. There's a lot of really good writing about this. I will share some stuff in the chat that I hope everyone can dive into more, because I realize we don't do justice to it in these whistle-stop tour presentations. But I really urge you to pay attention and to continue to go on that journey of learning about this, because it is about as flimsy as we're making it sound. And we are able to talk about it these days because of decades of work by intersex people, by allied academics and physicians who have really dived into this history and exposed it for what it is. But I'll end on this. One of the things in doing human rights advocacy and research, and I work on LGBTQ issues in all different contexts, and the intersex issues is not the only thing that I've been working on for the last 6 or 7 years, is when you start doing the on-the-ground advocacy, you go to these meetings, whether it be in Jakarta or Sacramento, to try to push for positive policy, you hear a lot of feedback from policymakers about what they don't quite understand, or what's their misgivings, what are they nervous about, and so on and so forth. And I think one of the things that really struck me in particular, I spend a lot of time listening to homophobia and transphobia in my job, right, from policymakers. And this is part of the job, is to get to work and sort of push back on that and give them another way to think about it. But when doing advocacy on intersex issues, we often hear from people, including from people in the medical profession who are perpetrating the human rights violations, including from policymakers, we hear this line that, well, this can't be a human rights violation because the people involved, the surgeons, the endocrinologists who are referring into surgery, they don't intend to harm. They're actually intending to help. And I want to be really, really clear that intent or not, it doesn't matter. And in fact, there's a lot of writing on this from human rights legal experts to say that it's nice if you don't intend to harm. If you still harm someone, you are still very complicit in a human rights violation. And I think that's a very important framing for going forward on creating affirming policy. It's not just about adding the I to your acronym. It's not just about, trying to be as inclusive as possible. It's actually breaking down this idea that, well, I didn't mean it. I didn't mean to be a bigot. I didn't mean to do this thing that had irreversible, non-consensual impact on your life and on your body. We got to throw that out, right? It's not about these intentions, and instead use that intentionality to be open-minded about, okay, how are we going to fix this, right? Because if we're surrounded by people who have great intentions but are still causing great harm, then we're kind of all complicit in that system if we're not calling it out. So I'll stop there. I will throw some stuff into the chat that I hope you can all click on and have 85 tabs open like I do most days. But I hope this leaves a little bit of time for questions. And thank you so much for having us all here today.
Thank you so much, Kyle. And thank you all so much for participating in this panel. As an intersex person myself, it is so special for me that y'all came to my school and did this with me and helped spread intersex awareness. I think it's very, very important. There is one question here that I thought was quite interesting. It says, is it true that there is a major lack of urologists in these subspecialties to help intersex people who had many surgeries that are prone to higher complication rates?
And yeah, that's absolutely true. I would say that there are really only 9 or 10 urologic reconstructive fellowships each year. And so if you can just think about it, that's just like a fraction of every physician who graduates each year, and they usually go to academic centers. And so like if you live in Nebraska, you'd have to go to Omaha, or if you lived in Montana, you'd probably have to go to Seattle. And because in Pennsylvania, you'd have to go either to Philadelphia or to Pittsburgh, because these specialists are few and far between. They're really busy, and quite often even though they've done a reconstructive fellowship, they haven't necessarily done reconstructive surgeries on intersex people. And so they have an experience of maybe 2 or 3, as opposed to, more common conditions. And so as a result, so many intersex patients bounce around from doctor to doctor. I know someone who's hoping to have surgery, but right now their insurance company won't let them go out of state. And so they've been living with urinary incontinence. I mean, it's just, it's a failure of transitional care and, patient abandonment in many respects. That, the pediatric urology who did those surgery is number one. They might have passed away, but they certainly never see these people years, decades later.
Thank you, Dr. Wong. We have about 2 minutes, so I think we can maybe cover one more question. So the question is, what do you wish to make clear to the healthcare system at large? Anyone can chime in if they want. I can say something too. I think that I wish that intersex people weren't looked at as patients who need to be fixed, because I think that most intersex people don't actually need surgical intervention, and they don't need to be fixed. And I think that going in as an intersex patient to a doctor's office, you very much feel like an alien, and that you are like such a special case, and that they want to fix you, and they want to like have as many people look at you as possible. And for me, that made me very scared to go to doctors as a child. And I think that just thinking about it as not something that needs to be fixed necessarily is very important. If anybody else has anything to say, go ahead.
Yeah, I actually want to circle back on that, because I now know both sides of the story, right? I was a patient, still am, more or less, but now I'm also a physician. So really what happened in that transition is I'm very self-directing my care. Even if I see a colleague for something, we just talk like, and this is the advantage of being a physician, right? You can really use that advantage. You can direct your care to a very large, if it becomes unreasonable, of course not, but I like to consider myself reasonable. Anyway, but the problem is it's this whole idea of fixing. What are we really fixing? For example, think about this. If somebody recommends a vaginoplasty on a 2 or 3-year-old girl, not knowing what their real gender identity is at this point, by the way, because they can't tell us, what would that achieve? Because look at the fact that we do these interventions and we really have to ask ourselves, what are we achieving with this? And the younger a child is, the more you might have to have further surgery. There are more and more complications. Every time you cut, there's a scar. You can't prevent that. That's just what tissue does. Tissue is stupid. You cut me, I'm making a scar. Now, once this person is an adult, after having this many incisions everywhere in a small area that has now kind of grown, you know, it really creates a lot of issues, but some other guy did it. So now here's the adult or urologist who sees the work of the pediatric urologist and say, whoa, who did that? And also, let's be real here. We do a lot of cover your ass, CYA here in this country, right? Because we're afraid of lawsuits. And that's just also a reality of medical practice. And, you know, if you are out there, you always have that in the back of your mind. So what if somebody blames you for something that somebody else caused and sues you over it? So you don't want to touch it. You have a natural like, ew, get that away from me. On top of that, the lack of education of adult physicians in intersex, because we have, by doing the surgery, by calling it a disorder, we have basically eliminated intersex. So that don't exist anymore. We only have binary sex characteristics, right? Because we fixed people. But you can never turn an intersex person into a physically, perfectly intact, typical male or female. You cannot. That is just not possible in this earth. So here we are creating people that basically we eliminated you. So you were either a man or a woman. And now we see all these other things that happened during that creation process. And it's just overwhelming because nobody had the education for it. The adult urologists, even adult endocrinologists, OB-GYN, were not educated because it all stays, the specialties stay within pediatrics. But by the time somebody's 21, the latest most of the time, it's bye-bye, see you later, have a nice life. You cannot go back to the pediatric specialist. And you go into an adult world where you fall into an abyss because they basically can't handle that. They can't handle this. This is something they never learned. And this is a gigantic lack of medical education. It is unbelievable that we are eliminating, you know, a whole section of the population in adult medical care. That's all I have to say.
Thank you, Dr. Kreuzer. And we are running a little bit over, but if anyone wants to stay, I'm going to share the trailer to the new Intersex documentary that's premiering this summer as we wrap up. And yeah, thank you all so much for coming. Kyleigh, do you have anything else to say before we wrap?
Yeah, I just wanted to thank everybody for coming. And if anybody is interested, you can join to go to the Southern California LGBTQIA Health Conference. It's the weekend of May 13th. Dr. Kreuzer will be speaking there, and Jessica and I will be there as well. I believe tickets are on donation only. So definitely donate, and we'll see you there.
Celebration. 3, 2, 1. Society generally considers that biological sex is cut and dry. Actually, it's not cut and dry. We don't fall neatly into that male-female box. I was born intersex, and although I was born with a vagina, I was also born with internal testes.
We live in a society that's so binary. So as an intersex person, where do I fit? The definition of intersex is any variation in a person's sex characteristics.
They told my mom, you have a child that we feel is abnormal, and this body was a problem that needed to be fixed.
And that I should never tell anyone about it.
It's therapeutically highly desirable to have them surgically corrected at an early age.
I just remember like a lot of pain.
In most cases, there is absolutely no evidence to suggest that surgery is medically necessary. I can walk into
The doctor changed the course of my life. I did not consent to that surgery.
I had to tell the world what had happened.
We've just been silent about this for so long.
I'm going to come out today. I'm going to tell the Texas Senate. I was born with balls.
I think we're at the cusp of something cool.
Our goal is to pass a bill to condemn these medically unnecessary surgeries.
A huge revolution starting right now. Just existing as an intersex person is grounds for celebration in a whole world that doesn't see us. But you know what?
I am intersex.
We are here now.
All right. Thank you all for sticking around, and thank you all for coming so much. Hope you have a good rest of your day.